Hello everyone, my name is Vladyslav Dieiev. I am a physician intensivist in Wisconsin, United States, and today I will be talking about mechanical ventilation. More specifically, about how mechanical ventilation common language can help us set and achieve ventilatory goals for mechanically ventilated patients in our ICUs. Let me start by sharing the inspiration for this talk. In 2025, with the assistance of Professor Dubrov, we have conducted the Education Needs Assessment Survey among Ukrainian anesthesiologists. Among 212 respondents, more than half reported more than 10 years of mechanical ventilation experience. Yet the biggest requests for education were still very practical. How to ventilate different patient groups, how to read waveforms and recognize desynchrony, and how to wean safely. And I can tell you that those questions are exactly the ones physicians across the globe are asking. This is the competency assessment of US and Canada physicians caring for mechanically ventilated patients. And according to this assessment, only 1 in 10 physicians has demonstrated how to measure respiratory system resistance. So why is that? Why all of us caring for mechanically ventilation patients don't have the common understanding of how perform those seemingly important competencies? Part of the problem is that ventilatory technology has evolved so much, and the mode complexity have increased exponentially in the recent years that led to variation in bedside practice. And when the variation comes to bedside practice, that leads to communication errors, inconsistent ventilatory goals, and harder onboarding for new physicians who are graduating from schools. So the goal for this talk will be to familiarize you with one approach of common taxonomy of mechanical ventilatory modes and how that taxonomy can be applied towards setting goals for your patients. Right now, most hospitals operate with Generation 5 or Generation 6 mechanical ventilators, and Generation 6 ventilators can have substantial number of mechanical ventilatory modes, but they are extremely variable from manufacturer to manufacturer. Volume control ventilation on one manufacturer model could substantially different from volume control mode on a different manufacturer. For example, just by clicking the small button called automatic tube compensation on volume control can transform the breath into the pressure controlled breath, but the name of the mode still does not change. So you can have a misleading information about what the mode is doing for your patient at any given time. So how do we bridge that gap? By going back to physiology, by going back to equation of motion and how it's applied to respiratory system. So let's examine what equation of motion for respiratory system looks like. Here at the left side of the equation, we have pressure of the ventilator. That's the pressure that the ventilator is delivering to the patient while we are talking about positive pressure mechanical ventilation. And on the right side equation, we have 4 parameters. 2 of them are patient characteristics, namely elastance reflects the lung parenchyma, pleural space, and thoracic wall, while the resistance mainly reflects the airway that starts from the mechanical ventilator tubing, involves the endotracheal tube or tracheostomy, and then major airways all the way down to bronchioli level. So that pressure that ventilator needs to generate on the left side in order to overcome elastic and resistive load of the patient body will be mainly through the volume that is expanding alveoli and interacting with elastic load of the patient body, and the flow which would interact with the resistive load of mechanical ventilatory circuit. So here are some names of the common ventilator modes that you might have seen on your mechanical ventilator: volume assist control, SIMV, etc. So how do we use that equation of motion, and how can it help us name those modes in a common nomenclature? Well, for that we will have agree that at any given time, the ventilator can only control one side of the equation of motion. It can either control left side, meaning it will be a pressure mode, or it can control the right side, meaning that we will be controlling our volume and our flow. And then the mode would be called volume control. So here we go. First step in naming any mode is a control variable. Control variable describes what is being held constant during the inspiration, and expiration is always pressure control. So during the inspiration, we can have PC, breath, if we are controlling the left side of the equation of motion, or VC, breath, if we are controlling the volume and flow on the right side of the equation of motion. Now the second part of any mode name would come from the breath sequence, and here we have three options. We have CMV, IMV, and CSV, and those abbreviations describe how mandatory and spontaneous breaths are being arranged on a specific ventilatory mode. It's important to understand or remember what spontaneous breath actually is on any given mode. We define spontaneous breath as a breath that was triggered by the patient and that was cycled by the patient. So only if those two parameters are true, the breath would be defined as spontaneous. If mechanical ventilator cycled the breath that was triggered by the patient, that breath would still be called mandatory breath. So if we have only mandatory breaths, whether they're triggered by the patient on the ventilator, the mode would be called CMV. If we have all breaths triggered and cycled by the patient, then the breath sequence will be called CSV. And if we have mix of two, then the mode would be called IMV. Third part of naming any mode involves naming the targeting scheme. So targeting scheme describes how the ventilator achieves certain target. For example, if we're setting up the volume control mode that controls, we're using assist control in a volume mode, classic volume control, we will set tidal volume, for example, for 500 milliliters. And if we set that 500 milliliters and the mechanical ventilator using flow, and to achieve that target volume, that will be a set point, volume control, mechanical ventilation. On the other hand, modes like PRVC can use adaptive targeting, where we set up the volume target, but instead of using the flow, we will be using pressure in order to achieve our target. And those modes will be classified as having adaptive targeting scheme. So now putting all three together, control variable, breath sequence, and targeting scheme will let us name the mode in its entirety. So let's make this exercise here. This mode, this is a waveform that we see on most mechanical ventilators. And on the top, we see the pressure waveform. In the middle, we see the flow waveform. And at the bottom, in the blue, we see volume waveform. So first step to identify which part of mechanical ventilation we are controlling. Are we controlling the flow or are we controlling the pressure? Well, ventilators are pretty good about achieving the targets that are being set. So here I can tell that the flow waveform look very square, so most likely we are controlling the flow. Now, there is no white blip right here or right here, meaning that the ventilator is likely initiated the breath, and also we can tell that the cycling was also done by the patient. So this mode will then be called VC because we are controlling the flow. It will be a CMV mode because all the breaths that we can tell, at least on this waveform, they look mandatory breaths because they were initiated and cycled by the machine. Additionally, we can see that the ventilator achieves the set target volume. So likely mode targeting scheme would be a set point. So here are some common modes and their names both in a common language and tag language that describes what they are, and some of the ones that might be very familiar to you, like SIMV. One thing I'd like to mention about IMV, or intermittent mandatory ventilation, there are 5 types of IMV, and it can be really challenging to understand which specific type of IMV patient is on, and reading manuals of mechanical ventilator could be extremely helpful to understand that. So now that we have discussed the language, let's talk a little bit about goal-directed ventilatory management and the goals that we can set while caring for the patient. So first step in caring for any patient who is about to go on mechanical ventilation, is already on mechanical ventilation, and it's to set up a goal. And there are 3 options here. The goals are safety, comfort, or liberation. When we say the safety goal, what we mean here is the gas exchange, meaning that exchange of the CO2 and effective transport of O2 across the alveolar capillary membrane, and prevention of vent-induced lung injury by limiting the pressure and the volume on the ventilator. When we talk about comfort as a goal, what we mean here is patient-ventilator interaction and synchrony, and optimization of work of breathing while having safety maybe as a secondary goal. And when we say liberation, what we mean is we try to minimize time on the ventilator. After the goal has been established, the next step is to choose the ventilatory mode that will let you achieve the goal. And if we are starting the patient on the ventilator, a typical starting goal would be safety, and we can choose appropriate mode for that. On the other hand, if patient is already on the ventilator, then assessing how patient interacts with the mode and maybe changing the mode based on the new goal is something that we would consider on a daily basis. Third step is to assess patient-ventilator interaction and what predominant load is currently exists on patient breaths. So by examining waveforms in the manners we just did with you a couple minutes ago, we can evaluate whether patient has elastic load predominance or resistive load predominance. And if elastic load is predominant, then we can make certain adjustments, and the resistive load predominant, we can make certain adjustments. And we can also understand how much muscular effort our patient has and how well they interact with the mode that we have chosen for them. So then, after we summarize all clinical goals, mode tag, the predominant load, and we classify patient-ventilator interaction, or PVI, we can then continue caring for our patients while reassessing goals, sometimes daily, but sometimes hourly. Here, I have a little bit more granular details for you about features of different goals, safety, comfort, and liberation, and a few modes that can be effectively used to achieve those goals. For example, for safety, VCC-NDS, or volume assist control, typically will be a chosen mode. PRVC is an acceptable alternative. For comfort, modes like pressure support, or PCC-SDS, can be used as a main mode for mechanical ventilation. And for liberation, we can use PCC-SDS, or pressure support, as a test in order to ascertain if patient is ready to be liberated from the ventilator. And here's an example how this works in real life. This is a patient who I just intubated a few days ago with pneumonia, saturating 90% on 40% FiO2, respiratory rate 14, tidal volume is set as 350. That's 6 ml per kilo of ideal body weight for this patient, so lung protective settings. And here, by looking at the waveforms, we see that the flow waveform appears a little bit more normal than the pressure waveform. There is a flow with every breath. So we are getting a sense that we are in a volume control mode right here. But then the pressure waveform looks very abnormal. Here we have PEEP level, and you have negative deflections on the pressure waveform that corresponds to the patient inspiratory effort. So instead of having a positive breath like so, we are actually having negative pressure breath while patient is on a positive pressure mechanical ventilation. And that we call that work shifting or severe PMOS, meaning that the patient work of breathing actually makes it difficult for him to breathe. So if our goal for this particular day is safety, which it was for my patient, then the next step would be to sedate patient or perhaps even paralyze them. But on the other hand, if your goal for this patient is comfort, then the adjustment of the mode to the pressure-based mechanical ventilation could be appropriate in this scenario. And here is just a reminder that every patient mechanical ventilation is a journey. We always start with safety, and pretty quickly, within usually 48 hours or so, we can transition into comfort, like the patient who was intubated for pneumonia. After pneumonia starts getting better, prioritizing patient comfort will let you decrease the amount of sedation that patient is getting. And as soon as patient is ready for the comfort mode, spontaneous breathing trials can be performed on a daily basis to understand whether your patient is able to be liberated from the ventilator and actually avoid tracheostomy if possible. Here's some useful guide from Mayo Clinic colleagues who have translated into Ukrainian as well. Some basic settings that can be used to achieve goal of safety in patients who have been just placed on mechanical ventilation. And here's ArdsNet protocol that many hospitals in the US are using in order to practice lung protective or safe mechanical ventilation. So now that we had discussed common language and goals, I'd like to spend a few minutes talking about how to make it work at your workplace. Well, one way to approach integration of this knowledge in your workplace is by combining education and implementation sides. Education helps you to build that shared language and skills that waveform interpretation recognition, while implementation is more about hardwiring some of those practices like sedation liberation and mode adjustment with a common goal in mind in your workplace. And this comes from the same survey that I've shared in the beginning. 82% of you have requested hands-on workshops, and 55% requested bedside mentorship, and 50% requested simulation as the main learning modalities, which covers different aspects. Workshops are great at building the shared mental model of modes, settings, and bedside adjustments. The mentorship is great about turning theory into the judgment during real cases and can help to build case reviews. And simulations are great for troubleshooting alarms and the synchronies in the simulated environment. The practical advice is for if you are thinking to implement this knowledge at the bedside, creating things like one-page ventilation, starter guide, short waveform case review each month, daily liberation checklist linked to sedation and mobility can help you to bring some of those good mechanical ventilation practices to the bedside. This is a Rosetta Stone of mechanical ventilation that I have at my workplace, and I encourage everybody to build it theirs. Getting Servo is the ventilators that we use. So here's a list of all the modes that this ventilator has in our existing models. And here's the name of those modes in the common mechanical ventilation language available for everybody. on the laminated cards who touches vent. The next aspect I want to preface with words of one of grandfathers of mechanical ventilation, Dr. Bjorn Ibsen, who allegedly said to his children at the tail of his life that I'm not afraid of dying, I'm just afraid of how. And he said those words because he has seen what his creation, adoption of mechanical ventilation, created in the modern world. Largely what I mean by that is that ventilator problem sometimes is not really about the ventilator, it's about sedation. Comfort, delirium prevention, mobility, and synchrony, they all affect liberation. So treating the pain first, using the lightest possible sedation, keeping your patient awake, moving, and performing SBTs or breathing trials daily has really been shown to improve ICU outcomes, shorten length of stay, and reduce need for tracheostomies. 41% of you report regular benzodiazepine use. While it's definitely understandable in limited resource setting that benzodiazepines can be acceptable for sedation, we know that those medication classes lead to substantial delirium complications. And mobilizing mechanically ventilated patients should be the goal for any hospital who has mechanical ventilator in the ICU. Here's another QR code with a guide from, again, Mayo Clinic from a certain project about how spontaneous breathing trials can be practiced. And here's a video from my hospital just from a little bit ago. This is a patient with endotracheal tube who is walking in the hallway with assistance of respiratory therapists, nurses, and other staff, of course. To achieve this, we needed to do a lot of education and work on our end to bring team together, have a buy-in from nurses, and making sure that everybody's on board with this intervention, which seemingly is very unsafe to have endotracheal tube potentially be at risk of migration in this patient. But in the end, we do believe that patients like this are able to be extubated faster and liberated from the ICU and avoid some of the complications of long ICU. Which brings us to the take-home points. Use common physiology language when naming mechanical ventilatory modes that will help you to establish goals for mechanical ventilation for your patients, such as safety, comfort, or liberation. Practice aggressive liberation strategy in your ICU by minimizing sedation, practicing delirium prevention, early mobility, and daily readiness checks. And finally, bring your practice to the next level by combining education in these areas with simple bedside implementation tools. Thank you for your attention.